Hey guys, welcome back. Today we're going to be talking about communicating assessment results right behind me here. Um, as soon as I turned on my cameras and my lights to record this, I realized that I sound like I'm sick because I am sick. And then I'm wearing a hat which is covering up my eyes. I'm going to kind of keep it above the hairline a little bit, but you don't want to see my nasty hat hair anyway. um, and sometimes when I do these kind of things like this, and I'm like, oh, I'll just wait till I sound a little better or look a little better or feel a little better. And then I'm reminded that you guys have to show up to class however you are. And with our clients, we show up however we are. And sometimes there are legitimate reasons to just say, you know what, I'm sick, I'm going to stay home, or I'm not going to do this kind of thing. But showing up authentically in front of our people, our clients, our coworkers, ourselves, involves us at our best and us at our worst. And of course, there are some boundaries to be set, but I try to show up as much as I can, just the way that I am with you guys. And so this part of this is like, I'll try and do my best here. If I'm really failing, you'll never know because I'm just going to stop doing this and I'll pick a different day to record this. We'll leave it at that and we'll get going. I may have to take coughing breaks too, and I choose not to edit these videos. So if I do, sorry in advance. I guess that's all I have to start with. A formal Midwestern apology from the bottom of my heart, which I think those are kind of an oxymoron, Midwestern apologies. Isn't that something you do sort of superficially just to say sorry, but then you don't actually mean it or something? I don't know, whatever. I mean it. I think you guys know that by now. Okay, communicating assessment results. Oh, also, one other thing that I'm going to try and keep in the back of my mind too, thank you, Camille, is she said that my head is covering up some of the text that goes across the screen here. So I'm going to try and kind of bop out of the way when I need to so you can actually read this stuff too. So anyway, I want to reiterate one thing that I keep saying over and over and over again, but I think it kind of needs to be drilled into our heads so much, is that the textbook that we're using teaches this very formal way of communicating the statistics and the science and the results of formal evaluations. And that's important. But the other thread that we're sort of working our way through in this class is not how do we communicate those formal test results, but how do we communicate our understanding of what we think is going on with this other person, or what we think is going on in our heads. Some of that is, here's how I understand what your diagnosis might be. Some of it is thinking through, like, here's what I think of you. Here's my reflection of your character. One of the most beautiful examples that I've heard in a long time came up in an internship class just recently. And I'm going to totally butcher it, and I'm not going to give you the long version of the analogy, but it was so good. But it was basically the idea of, like, clients come in and we just hold up a mirror and say, this is what I see in you. And so often we get this idea of ourselves or our past or the people around us, the external world, the politics, all these things, that it is a certain way or we feel a certain way about it. But when someone holds up a mirror to us, we're like, oh, I really look like that? You mean the world isn't actually the way I see it? That external reality that I think it is through my rose-colored glasses doesn't exist out there to other people in the same way. And so part of what we do is we assess how accurately is a person seeing themselves and the rest of the world, and do we hold up a mirror to that and say, this is what I'm hearing, and it's reflecting back to them. This is what I'm hearing, and this is what I'm understanding. Is that what you mean? You mean you hate everybody? Okay, well, that's a different story than, well, I don't really hate everybody, So our part of assessment there is not necessarily like finding a bunch of information and doing these wild things with them. It's just saying, here's what I'm hearing from you. Am I understanding it right? That understanding helps people understand themselves better too in the process. So anyway, we're following these two big threads in the counseling world, in the therapeutic spaces. So there's that. The other thing I'll say kind of at the outset with this lecture too is, considering that we're talking to, some of you are school counseling and some of you are mental health counseling, there is a therapeutic context in which we're thinking about these things. And that's oftentimes more of that informal, holding the mirror up kind of stuff. But there's a really important communicating data, especially when it's large scale data, to other stakeholders. And I'm going to use that kind of buzzword because that's parents, that's community members, that's how our kids are performing in school, that's what's happening performance wise in our schools, that kind of stuff. And that's a big topic, and it's an important topic, especially when, and this is another thing we're bringing up in class, when assessments are made for making big decisions, lots of people involved over many periods of time. That's sometimes why we have to use assessment tools to help us organize how we're collecting, manipulating, and sort of changing data in order to understand it differently. And that oftentimes happens with more people over more periods of time, something like that. So in our mental health world, we want to know how people progress and change over time. And that's what is more sort of the research focused parts of this assessment stuff. So anyway, there's an important role in there. So I'm going to switch back and forth between those two things. Okay, so let's jump in. Here's a few considerations. These are all just kind of random thoughts, but are you communicating in writing or verbally? So we'll get some practice here in class and some of our assignments, writing notes, progress notes, writing our own personal case notes. And those are two kind of different things. Progress notes are part of the health record that are confidential, but they get shared with insurance companies. Sometimes they go into our electronic health records. And then there's like the notepad you have with clients' names and their families' names and that kind of stuff in it. So are we communicating any of that back to the client verbally? Are we communicating it to other people verbally? Are we doing that in writing? Are we letting a client see our notes? Some people do, some people don't. Some people say you can see your record upon request, but typically clients don't see the diagnoses we make for them and stuff. Well, I shouldn't say typically, but a lot of times they don't. So how we do that and who we're communicating to is very important. Okay, so there's a bunch more to that, but we'll move on to the second point. Who are we communicating to? Is that to clients? Is it to parents? Is it to a referral source? Sometimes if you guys work in like let's say the drug courts or some kind of court system, and you know that your report is going to go back to a judge or a parole officer or a social worker or something like that, that might impact the kind of information you send back to them, the kind of things they're wanting to know. In other words, is this, for example, if you work in the AODA world or the substance abuse world, sometimes clients will get sent from the courts over to just be a part of counseling. And I think the technical language is something like, do you engage in the counseling process? Well, what engagement looks like depends on your relationship with the client and how that works out. And oftentimes clients will say like, I'm here, I'm going to sit in the chair, but you can't make me do anything. And you're like, all right, well, I have to report back to the judge about your engagement here. So let's, you get to do whatever you want to do, but I get to write the report too. So help me figure out how we can do this in a way that works for both of us. So that kind of thing happens too. So who the referral source is really matters and what they're here to get. Another example, we'll bring up more of these examples in class too, but like if a husband comes in and says, I'd like to join couples counseling and my wife doesn't really want to come, but she's going to come because I asked her to. The referral source is husband, and that tells you a little bit of information about what the wife's attitude might be coming in the door. So how you're communicating to the couple themselves might be received differently. And so that's another sort of consideration as well. There's always going to be unique challenges with each one. So some more to talk about there, but we'll just start there. Communicating performance is part of an ongoing assessment process, not just something that happens at the end. So when we say assessment is not just session one to make a diagnosis, then you put it aside. Assessment informs treatment plans, and then you talk about, it's not just like you take a test and at the end you're like, okay, the test is done, and then we're done with it. Where a person is in their progress is an ongoing thing. And what this looks like when I'm doing therapeutic work, even if I haven't done formal assessment, is I might be like, well, this is how I understood you at the very beginning. I assessed you to be this kind of way or with these kind of symptoms. But the more I get to know you, the more you look like this. And so now I'm seeing a person that acts this way or thinks this way or feels this way. And so that's an ongoing thing that I'm telling clients, like, your understanding of me and my understanding of you is this constantly evolving, developing thing. The buzzword is it's dynamic and it happens back and forth and it's ongoing. So it's not just something that has like a formal stepwise process. It can be that, and that's absolutely okay if it does. when I do work that's more evaluative and less therapeutic, in other words, if someone's like, I just need a diagnosis or I just need you to do this assessment, then I walk through a pretty formal process of like, okay, here are the steps. Here are the boundaries that are a little different than when we do therapy. And here's what I'll give you in the end. You'll get this report, and that'll be the end of our relationship. And that's perfectly fine. It can be just something that happens at the end, but it also doesn't have to be. It sort of depends on our role too. If we are going to walk through that process, like some of the formal steps of the process here, we want to start with setting expectations. I write informed consent here. We talk very specifically about informed consent as if it's like the speech you have at the beginning of the counseling relationship related to confidentiality. And it is that, but it is also just letting a client know, here's what this test is. So just sake of example, last week we were in class and you said, can I ask a question about the stats quiz? Because I really want to know, this is 2 weeks ago probably. I really want to know like how many questions it is and what kind of questions are going to be on it. And I want to know what it's going to mean for my grade and like all that kind of stuff. And that was the informed consent process, because I said, here, I'm going to inform you. And you didn't really have the opportunity to consent. You just kind of had to do it. But it was, we'll call it voluntary, I guess. Probably not fully voluntary, but nevertheless, setting expectations is an important part of that process. And we did that in class, and you get to do that with clients too, depending on what kind of assessments you're giving and what your understanding is of them. Even when it's an informal assessment, sometimes I don't always do this, but I try to do it if we can squeeze it in. But I'll talk to clients sort of like in the context of what they should know about me and how I'm going to communicate with them. So, like, for example, someone comes in and says, like, I want therapy and I'm going to work on my, I don't know, whatever, anxiety or this phobia or OCD or something like that. And I'll say things like, I want you to know that I want to share as much as I can with you about you as we go here. And I really, if this is going to be a trusting relationship, that means you have to kind of know, or I'd like you to know what I think about you and your progress. And then I have sometimes ask like, do you want me to give you feedback that I think is going to be constructive, but kind of hard to take? Or do you want me to be comforting and soft, like that kind of stuff? We'll have that kind of conversation. It's just to start setting expectations about what do you need from me? What's going to work best? So anyway, enough about that for now. What will the results mean specifically? When we talked about this stuff in the stats chapters we just did, part of that is just communicating what is actually going on here. And we use the words mostly in class, but maybe in some of the lectures too, of like translating this into language that people understand. When I say specifically here, do we mean with scientific accuracy or specifically to you, uniquely to you as an individual client or something? So you can interpret that however you need to, depending on the context. And I guess number 3 kind of says the same thing, so we'll just skip over that one. One of the challenges, number 4 here, one of the challenges in using language people understand without misrepresenting, this is like the same thing I just said. So here, I'm going to scoot out of the way for you, Camille, and everybody else who has the ability to see and wants to see what's behind my head. There's a lot of opinions about what is right here, about the right way to have this conversation. The one thing I guess I'll leave you with is that there are the words that I say, and there's generally a way it can be done. But you get to find your own style and the way that you represent this stuff, the kinds of information you share. The more you talk to clients about what their results are, the more you'll find out what really matters to them, and also what they probably need to hear. And sometimes those are hard things to sort out, because it can be real easy to just say like, you just want to hear the positive news. And I also just want to give the positive news, but sometimes I have to challenge myself as a counselor to give negative or critical feedback to people that might just sort of help them see themselves better or in a more sort of truthful fashion. And they might lost my train of thought a little bit already. But I challenge myself to be as honest as I can, also within the context of it has to be beneficial for them. And they might Yeah, I forgot my train of thought already. I'm gonna keep going, even though I'm messing up here a little bit. But um, the language of what works, it has to be a relationship between what works for them, and making sure I'm doing what I need to give them the best I can give. So sorry if that came out all goofy. this is this is me and not my best. Uh, I also think one of the benefits of doing things like this, where I'm just like I'm kind of embarrassed making mistakes like this, but it's also an opportunity to say like, hey, we're not always perfect, we're not always our best, and you can have the experience of embarrassment without having to like try and cover it up and redo it to pretend like we don't have these parts of ourselves that have this very normal human experience of I don't make perfect decisions all the time and I don't say things right all the time. Um, and so just this little self forgiveness, and then I'm going to move on. So that's what I'm going to do. Um, there are some verbal examples in your book on page. I don't have my book; it's over there, and I don't want to get up and go get it. Does that mean I'm lazy? It might mean I'm lazy. I don't know. No, no, I'm managing my fatigue since I'm sick. I get really tired. That's what I'm doing. Sure. Um, but I'm not going to go get it, and I can. You guys can go look at it though. But there are verbal examples of how to talk about statistical things to other people, like parents and that kind of thing. So you might want to check that out because, especially for you school counselors, I think who are going to have to really communicate more of those formal statistical examples or assessment outcomes and that kind of stuff. That can really give you a little bit of guidance too on those. So, okay, I'm gonna pull down my uh, what is this transcription here so you can see what the title of this thing is. Problem areas and assessment feedback. In other words, what makes this hard? Why is it hard to do this? When all this list is not why is it hard for us, but why is it hard for clients? Why is it hard for them to sort of receive feedback? So number one, and then there's a lot of redundancy here, so I'm going to kind of skip around a little bit, I think. But acceptance, people distrusting or not liking the results. How much have we sat in this class and said, well, these tests, they're not completely accurate and they really sometimes do more harm than good. So maybe we should just sort of disregard or, not really take in the value of them. And I've had to do a little, well, we'll say arm twisting, maybe, or convincing, cajoling. Is that even I don't know if that word fits here, but nevertheless, part of my task is to talk about the value and to help us all understand them. And not all of us want to receive that very well. And that's okay. The acceptance process is part of us learning. And clients go through the same thing too, especially if they're eager to get the results, then that's oftentimes they're like, I really want to accept it, whether it's right or not. So sometimes we have to sort of pump the brakes and say, let's proceed with some caution with these results. Other times they're like, I don't give a crap about what you say and what that thing says. The man tells me I'm whatever. I'm not going to believe it. And then we get to say, okay, well, let's talk about how we can maybe digest a little bit of this, but we don't have to take all of it, something like that. So that's part of it. Readiness, similar to acceptance, but readiness to accept results is not about like, I'm not going to accept it, but I'm not going to do it yet, something like that. A little, I guess it's maybe the redundant part, but kind of like an example, the alcoholic who's required to take an assessment but doesn't want to hear any of the results. Very common thing if you're working with chemical dependency, substance use, whatever. I heard an interesting thing the other day from somebody in a class, and they said that they work in two different groups in two different they call them AODA clinics or just substance use clinics, whatever. And they said it seems like the people who are there for drug possession or drug use are much, much, much more willing to accept that they're there for a drug problem. They're willing to name it and talk about it. But the people that are there for alcohol stuff, they don't really consider themselves to be having problems, to be alcoholics, or to have any kind of like responsibility for that condition. And they said it's just really unique to those different groups of people, how they respond and kind of their readiness to accept their situation. So very interesting. There's probably a lot to talk about there, but we'll move on from that. Negative results. Who wants to hear something negative about them? I think I told most of you the other day about the time I took the MMPI when I was in school in doc school, and there's one category there that came back really high, which was psychopathic deviance, which I still think is funny to this day. But I shared the story of why I don't think I'm psychopathic, and so does my professor, and we talked about that too then. But I'm not psychopathic probably, and also I don't have a lot of deviance, but that it can capture protective factors that we use to insulate us from, being in high stress programs where you're being told what to do and how to be, and you're like, I'm not going to do that. Kind of sounds like deviance, and it's probably just a survival strategy, which is the psychopathy part. But my initial reaction to the negative results was, no, thank you. That's not me. I don't feel that way. I can't be I'm not deviant. You know what I mean? I mean, I don't always follow the rules, but I try to. I try to stay above board and make good ethical decisions and be a moral person. And like, I don't know. I just don't. It just didn't ring as genuine with me. So how we help other people understand what the results mean and how we communicate them can really make or break their acceptance of them. Now, the tricky part is, do we make them sound like euphemisms and make them seem not that bad, or do we use these dysphemisms and are like, take these harsh words because people need to hear the cold hard truth? How we do that is where this gets tricky. Flat profiles. I'm not going to talk too much about those. Maybe I'll show you an example in class. If you can remember to write this down to ask the question in class, I'll show you an example of what a flat profile looks like. But if you think about some of the scales we've looked at and the assessment results, where there's like, they're low in this one, high in this one, low in another one, high in another one, and like, the results indicate something more clearly, like this symptom chart really shows that this person appears to be depressed or anxious or has conduct issues or whatever the thing is. But flat profiles would be like if somebody sort of scores in a flat line across, so they're not high in any particular symptom, they're not low in any particular symptom. It just seems like they're sort of stagnant across. They're really tricky to interpret then because it doesn't really point to a specific diagnosis. So what do you do about that? They Depending on the assessment, they can mean different things. So I can show you an example of one and give you an interpretation of it, but it's hard to do right now without seeing it. So I'll skip over that one for the time being. Motivation and attitude, not wanting to see results they might feel are imminent. It's kind of like, I want to keep my head buried in the sand kind of thing. But some of the responses are like, this thing is stupid, which is just a way to push away something that is a reality that I might really want to hear. I might need to hear it, not sure, but it's just a defense mechanism. But it's hard to communicate to people if they don't want to hear it. So what do? Don't communicate it to them. It's not always that easy, because sometimes you're like, well, this is important that you hear this, and so sometimes you have to do a little convincing. But most of the time, it's like, well, if you want to hear them, you're welcome to hear them, and sometimes people do, and sometimes they don't. But context specific. I'll let you look at table 17.1 on page 399 if you want to, for feedback on parents. That's probably more for you school counselors. I'll let you take a look at that, but that's a pretty important chapter for you guys. If anybody's working with kids, then this will be relevant, but it's not relevant enough that I want to talk about it, because the way you communicate with parents is in like therapeutic settings is not quite like this. It's helpful in some contexts, but not enough to spend some time on it. So the one thing I will say about this last part here, about what do I do if parents don't like results or want a second opinion? And it's the same thing I say to clients if they're just meeting me for the first time. I say something to the effect of, excuse me, something to the effect of, if you don't think they're accurate, or you don't think that I've done the work that I need to be doing, if I'm not doing the best job, or if you just want to make sure because it helps settle your mind that you are choosing the right counselor or getting the best results, then by all means, please go and do this somewhere else, and then either stay there if you like the results better, come back to me, whatever. but my commitment is to giving you the best care or the best results, the most objectively accurate and that kind of thing. Because I people should be out getting multiple opinions. People should be taking in information from multiple places. And to be offended that somebody would like not want to see me because they don't like me or something, I'm like, well, I'm not going to be a fit for everybody, and I make mistakes too, and I don't want to make mistakes. And so, if you can afford to go get another assessment and get a second opinion, then by all means, please do. Um, so I usually that's a pretty disarming when people are like, "Well, I don't like this." I'm like, "All right, I wouldn't if I didn't trust it, I would want to get a second opinion too. So please do." In fact, I do get second opinions when I go to I don't know doctors and contractors and all kinds of reasons why it's good to get multiples. So there's no need for salesmanship here or defensiveness. I don't think. Usually when there is that kind of thing, like when I talk to people about this process of explaining like the value of your services or the outcomes of your work or something like that, there's just this like I want to believe that I've done all the steps right so much, or that I didn't make mistakes, or that it's my own self-preservation that gets in the way of communicating something to families and people that that I'm gets in the way of saying that you need to do your due diligence to protect yourself from my fallibility. In other words, I can make mistakes, but if I don't understand that and allow for that to be the case, then I'm not helping people get their best information or be their best selves or whatever. So feels like that didn't come out that clear, but hopefully it came out clear enough. I think what I'm trying to project there is a sense of humility and fallibility that, if this isn't working for you, then that's all right. I may not be perfect all the time, but if you're willing to accept my imperfections, then we can do this. And if you can't, then you need somebody perfect, and good luck finding them. This is a free country and you're free to be wrong. No, I'm just kidding. Someone said that to me once. I thought it was funny. Okay. The purposes of assessment reports. So one of the things we haven't talked a whole ton about, and we're going to start talking about them as we move into our final project for the semester, is reporting. We'll talk about note taking. We've kind of alluded to it a few times, but we haven't really specifically talked about it. But why do we have to write this stuff down? And why do we have to document at all? And there's various levels of documentation, from the notepads that you keep on your lap that you write, names and details on, to the stuff that goes into electronic health records, to formal reports, which is what we're going to do. Formal reports that you put in somebody's file that have like a long evaluation about whatever you're testing. So some of you won't do any of that in the future, and that's okay. Some of you will do some of that, and we'll talk about pros and cons of why you might not, probably later. Maybe today, but we'll probably in class. So you want to describe the results to the client. I mean, that's ultimately your fiduciary responsibility. In other words, you're there for them, and this is for their benefit. So they have the right to know what is going on with them. You want to record and interpret the client's results, performance on instruments. So like you gave them a test, what was the outcome? And then you're probably doing it for a referral source. Either the client has self-referred because they want to know. It could be, I mentioned the court example. It could be that a company pays you to come in and do some evaluation with their clients, or you're doing this for child custody, or you're doing it as part of a marriage retreat, and you are giving results to the couples at the end of it about their progress, or tons of different reasons why people can be asking you for something more formal. Just a little bit of a deviation, but they're sometimes in narrative therapists, what they'll do is, as clients are telling their stories and going through their sessions, they'll write little notes to their clients to take with them through the week. And I always never really done that. I always thought it was such a great idea. But it's a little note about like, here's what I see in you, or here's something, it could be anything really, but communicating how I'm assessing you is part of like, here's how I feel about your story. Here's the progress you've made. Here's what I like about you. Here's Sometimes it's positive affirmation. It could be any number of things. But the referral source is the client, and then I'm communicating back to them. Or, in this case, it could be somebody else too, just informally. It doesn't have to be like a super formal thing. And then, of course, the last one is make recommendations for future care, treatment, training. In other words, we'll go through this a little bit more too, but there's this cycle of person comes in, they want help. We have to figure out, how can I help? That's the assessment process. Then we report back to them, okay, here's what I think we can do together. Here's the work we can do. Future care, here's the treatment, here's the training we're going to go through, etc. So that's what we're really trying to describe here, is that cycle of, you want help? Well, here's what I have to offer. So that's it, the gist of it. There's this list here for the number 2 part, and then there's another one here that I'll show you, but this is kind of just a list of like do's and don'ts. I don't want to spend a ton of time on this because these are sort of self-explanatory, but you'll want to revisit these. One thing I recommend is looking at a list like this, and there's, I think, the other one right here. I'll show you that in a second. But look at this list when you've written your report and come back to it and say, have I used jargon or counselor talk that other people would just not understand? Is it overly technical? Have I not defined my terms? By the way, I'll give you feedback as you're writing parts of this and hand it in. I'll be looking at things like this and say, nobody's going to know what that means. Maybe choose a different word, or you use this acronym, but you didn't say what the acronym was. And like those kind of things, I'll help you pick those things out as I'm giving you feedback. Abbreviations not described, as I just said, poor or illogical explanations of results. Sometimes we understand things and we take for granted what other people don't know. And so I'll help with that in your papers too, but we really want to look for those places. Vague recommendations. This one's a little bit specific. Well, not specific. How do I say this? There are some people out there who, when you are writing for your electronic health record, or you're reporting to an audit, or not an audit, but like to insurance company or something like that. If you're just like documenting for your hospital job or whatever it is, there are a lot of people who will say, don't get specific about the client's details. You don't want to be identifiable about their details, but it is perfectly okay to say, the treatment is 6 sessions of CBT for 6 weeks. And that sounds great. It sounds kind of like take 2 Tylenol twice a day for the next 6 weeks, and then the course of treatment will be over. And it's fine. And there are really, really important and good reasons to be vague about that. On the flip side, there are other times when it's really, really important to be very specific. And so it's hard to give you examples of like exactly how to do both of those things. But once you get out into the world and you start documenting, some of you are going to work in places where you just want to be vague all the time. And you'll be like, why would you ever want to be specific? And I'll be like, yeah, okay. But there's these other cases, and others, when I worked in, I would do like forensic kind of stuff, and I would do these evaluations, and I wanted to be very specific of like, here's where a person is making progress, and here's where they're not. Here's what's working, and here's what's not working. And I wanted to be as objective and clear as possible. And so I didn't want to leave things out. And so in some cases, I wanted to be really specific. In other cases, I'm like, for the client's protection, I want to be very vague. So this one, because I'm giving you this sort of two-faced example, be vague sometimes, but not vague in others. When you guys are doing your writing and your work, it's going to be a little confusing, because sometimes I'm going to say I need more clarity, and other times I'm like, yeah, you probably don't need to write that much. This is just a hard thing to learn and to teach and to figure out. Once you get out into the world, you're going to be at your workplace. That's where you'll really want to like figure out, okay, what are the expectations here for reporting? And you will figure that out. You'll get some feedback from people around you and supervisors and stuff like that. But that's just going to be a hard one for us always, I think. And there's probably a conversation we could have about that one too, but we'll save that for later. For organization, one of the important parts about, I feel like I get like kind of overly anal about formatting, not APA formatting, but just clarity and readability. And that involves indentation and bold facing and italics and that kind of stuff. And I feel a little picky about that kind of stuff. But at the same time, if something's not organized and information is redundant or it's like all in one big narrative block, it's really hard visually to see how information is split up and if done well, it can be very easily readable and you can consume a lot in a short amount of time. If done not well, then it's really hard to find information that's useful and we just end up giving up. So I'll help you with that part of it and give you some examples and stuff. Um, if we overemphasize numbers rather than explanations, or vice versa, if we don't show the numbers and we just rely on narrative, there's a balance there. I don't want to say much more about that really, but we'll talk about that in class when we go through examples. And then exclusive use of computerized results. We've discussed that before, but if you get like an interpretive printout, make sure it's legit. In the world of AI responses and Chat GPT or Chat Jippity, as I like to call it. I heard someone say that once and I thought that was funny too. Chat Jippity. In the world of easily accessible summaries, we want to be very, very careful that we're not just accepting the summary as truth and fact and a reflection of reality. Whenever I get stuff like that, I always go back through and just change the language a little bit to make sure that either it's just my words and that I chose them, even if it's just an exercise and they did it better than I could. Sometimes I'll go in and I'll just edit a few things just to say like, this is my words. It's something that I said, partly for my own integrity, but partly so I actually review all the lines and don't get lazy and skip over things. So, okay, here's another one, kind of repetitive. I'll avoid being redundant, but second bullet point here, referring to yourself in third person. Some people like to say, the counselor said this, or, don't use first person like I said this, or use your own name like Aaron's. Everybody has different expectations. Everybody thinks they're right. I don't know what's right. There is no right or wrong really in this case, but you'll learn in your unique environment what the expectations will be. So I don't know. I don't like number 2. Let's just forget about it. I will say this. It's more formal to refer to yourself in third person. It's also real goofy. So you decide if you want to be goofy or if you need to be formal, then you can be formal. That's okay. Use simple words and concise sentences. You'll hear me preach about that from my pulpit all the time. Being excessively wordy and just being sort of verbose and narrative about it just doesn't help add more detail. In fact, simplicity is just quicker you can get there, the less you have to write and the less anybody else has to read, really. So number 5 is pretty self-explanatory. Number 6 is kind of helpful. I don't write like this because I was an English and philosophy major in college. So like I came from this creative writing background. So this one's really hard for me. But technical writing, if you remember back to like, what would it be like, high school or junior high English classes where they said, okay, you write a statement and then or declarative sentence, and then you write like 2 or 3 supporting sentences that explain that. And then you wrap it up with a big bow to say, here's what, and then in summary, and that's how you write just a standard paragraph. So your declarative sentence starts at the beginning, followed by information. Sometimes what I do and what I see other people do is they'll like start to tell a story and then they'll get to the punchline at the end and save that declarative sentence for the end. A different way of thinking, but it doesn't really work that well in this technical context. So try and say what you need to say as clearly upfront as possible, and then decide how many supporting sentences I need to justify that claim. So you can find other YouTube videos about how to become a better writer on that. I haven't, and I'm not going to be a better writer. I'm just going to practice it more as more as I can go. Now that I'm saying that, I'm like, I probably should go actually practice that a little more. But that's a tomorrow problem. Writing background information in past tense versus what's going on now. Most of the time, when I write things, I don't write in present tense because I write background information in past tense, but even if I saw a client on Monday and I'm writing this on Tuesday, Thursday, whatever, Friday, I'll still write in current tense because I'm writing about their current condition at this moment, even if it's a week out. So there's some times when it fits to write in present tense, and other times where you're writing about their story, about their growing up or family or whatever, and that's in sort of past tense. So just pay attention to that. Um, are they talking about their mother as the relationship stands now, or the relationship that happened back when? So irrelevant information, that one speaks for itself. Capitalized test titles, sure, self-explanatory. And then don't get sloppy, punctuation, grammar, all that kind of stuff. So, oh, there we go again. I'm standing in front of it. I'll let you pause it if you want to see more of it, but that's it. Okay. Check the time, 40 minutes. We got just 2 left. All right. We're doing right. And this one's an easy one. Report sections. This list right here is about as generic of a list as I've ever seen. Depending on the kind of report, and that's a good thing too, by the way. It's not meant to be a criticism. Depending on the kind of report that you're writing, you may have more, you may have less. So I'll walk through these just briefly, but you're always going to want to have a title. Like, what is this report for? What kind of report is it? Is it evaluation for parental fitness? Is it a career readiness evaluation? Is it a report for I don't know, a fit for therapy? Is it a report for completion of the therapeutic program? Whatever it is, it needs a title. You need to explain what that is. People need to know what it is. A psych eval, a neuropsych eval, whatever. The reason for the referral, we'll get some practice with that one. That one's kind of most often the one that students particularly don't think about the most, but it's almost one of the most crucial parts of it. And it may not make sense at first, but we'll get to it. Once you try it out and you write it and then write your first report, you'll be like, oh yeah, okay, I get it. This makes so much sense. So we'll skip over that one for now. Background information. The hardest part about writing background information is how much to write. And the hardest part about being a good writer is figuring out how can I write enough details to tell the story and no more and no less. So if you've ever read like Hemingway was kind of like the father of the minimalist writing movement, I think. Some of you English majors can correct me if I'm wrong, but he didn't fluff up his not like he was writing War and Peace or Anna Karenina or one of those like Russian novels that are like, or Les Mis, they're like this thick, 800 pages long. The minimalist people said like, we don't need to go on 15-page explanations on the color of an apple. We can just say it was red, move on, So they had, or they're focused more on plot and storytelling and character development, that kind of thing. Anyway, the point is, say as much as you need to say and don't say more, right? The question is, what's the quote unquote right amount? So when we're writing background information, one of the things I'm going to challenge you to do, and we'll say much more about this as we go through the process, but if you're writing, if your goal is to provide a diagnosis for the client or for the referral source, then you don't need to write everything about their trauma history and their background and all about their, their cultural experience and their sexuality and all that kind of thing. If it's relevant to their diagnosis, then maybe. But you can also get away with just mostly writing, here are the symptoms. Here are the symptoms that I understand them to have. And you probably don't need all kinds of background information. It's just sort of getting in the way. If it does provide good context for where those symptoms came from or how they developed, then yes. But making those decisions is where the practice comes in, and where like the really good writers versus the great writers, or inexperienced ones versus the great ones. That's where oftentimes a lot of those decisions in terms of what information do I include come in. So much more to be said about background. Behavioral observations, that one will make sense when we get to practicing those, so I'll skip over that one for now. What assessment instruments you used, we'll get practice with that one too, and I'll show you examples, so skip over that one for now. Same with results and interpretations for that. The summary. Sometimes if you're using more than one assessment, you may want to make a summary about what the results were and what your understanding is of that client or of the outcomes of it or something like that. The recommendations, this is a little bit of a tricky one too, because, and we're not really going to focus a whole lot on recommendations here, but it's kind of like their treatment plan. It's like, okay, I've assessed them to have this condition. Now here's what treatment is going to look like. We'll watch examples, and we actually already have watched examples of what this looks like, of developing therapeutic goals while doing an assessment. They kind of happen together oftentimes when you're doing therapy. Usually my style anyway is to do it during the first session. What I say to people is, by the end of today, I want you to have a good sense of what we might work on, or what it might be like to do this with me. If you don't, then I haven't done my job. I haven't assessed correctly. I don't understand you, and you have no idea what this could be like moving forward. So that's kind of the goal. But when you're writing evaluation reports, recommendations look a little bit different depending on the referral source and what you're supposed to be getting out of it, what information you're supposed to provide. So a summary of the if it's a diagnostic report, summary of the symptoms and the outcome diagnoses is the recommendation. They're kind of the same thing. Other times we split these categories up. So there'll be more to come once we get into that part of this process, and that'll make more sense then, I think. A few other things that you might add in that are relatively common depending on your situation. I usually include something about educational background. If you're doing work in schools, then you're clearly going to want to add something about education. However, if you're doing a therapeutic report and someone's coming in to be seen for, I don't know, let's say, a kid used to have reactive attachment disorder, and now they're had a diagnosis of bipolar 2. If there's something that happened during their school years, those formative years, that changes our understanding of the diagnosis, great. We don't need to know their grades per se. We don't need to know. I mean, if we think that something about their bipolar condition is a result of their grade performance because of treatment at school or something, then maybe. But we don't need to know like their GPA. It's irrelevant details. But if they say, I'm anxious and I was bullied at school, and I had these friends, but I started being anxious when I lost one to suicide or something like that. That's a pretty important part of their educational experience that led to the condition that's present today. So when we say education, we're not looking for like standard details that, about their classes and whether they like their science teachers or not. You know what I mean? So, education is one area where I think it's helpful to ask about. Depending on your work, medical history might be really important here. In fact, I mostly include that just about always when I'm doing things like this. Substance use history, legal history. These are all categories that you might choose to add in that you might find to be pretty important. If you're doing family, like couple and family kind of work, sort of in that MFT space, then you might include spaces about family history too, which usually that's part of background information. But like if you have a specific place for like genogram kind of mapping, that kind of stuff, you can do that too. Sometimes financial history, with a caveat. I don't ask people a lot about their financial situation other than, do you have stress around finances, that kind of stuff. So anyway, there's more to be said about this, but just know that you can adapt this because this is still pretty generic. Okay. This is the last one. Yep, this is our last one. So one of the things about the language that you use is, who are you talking to? I've kind of alluded to this already, but are we writing our report expecting that other service providers, other counselors are going to read this? Is it the judge from our, court-appointed clients? Am I working in a bigger hospital system where other psychologists or psychiatrists or physicians are going to read this? If so, then I may choose to use a little bit different language, use more jargon, use more of those Latin terms. And remember when I said, like, you don't want to be overly wordy or sort of talk above people? Well, if your audience is an audience of physicians that are likely going to be reading this, then you may want to to use the language that gets used in that space. And so um, it does seem like I'm being a little two-faced here about this, but really what I'm trying to project is this sense of adapt to your environment. If you need to sound like a professional, look like you know your stuff and you actually do know your stuff, then show it and don't be shy about that and be proud of what you know and the language that you can use and the way you describe to clients and that kind of stuff. Like you can do that and that's okay. The question is, what's the motivation? If it's to communicate to other people in a language they understand, perfect. If it's to boost your ego or to cover up your insecurities, not so good, right? So um, use your jargon language if that's the community that you're in, but just be aware of that it's going to be inaccessible to other people. But that can be okay depending on the environment. So sometimes what I'll do with clients or evaluees, if they're being referred to me from like an attorney or something, and the attorney is paying for the evaluation, then they're technically my client. But the evaluee is the person. I'll say, I'm going to use all these words, and here's what these words mean. This is what it really says about you, but this is what I write because this is what's expected in this environment. So I'll do a little of that translating for people if I need to do that, if it's appropriate to do that. Another thing too about number one here is don't necessarily assume that people know what you're talking about. It's so easy for us to slip into this. Like we talk about CBT as if like everybody in the world knows what CBT is, and people don't. you and this is, I think, has something to do with our confidence level and our confidence in our own understanding. Because you're in school and you're in this environment where you have these professors who are so super smart, right? Like all of us are just brainiacs and we know our stuff. And then you're a super, I'm joking, by the way. And then you go to a supervisor and their supervisors are supposed to train you. And like, so you're just the underling who just doesn't know anything. And so we're in this environment where we're almost trained, kind of like this learned helplessness idea that we don't have this specialized knowledge. And then we get out to the world and we start to realize when we get in practice that we're like, I have something special that other people don't. And I have knowledge and information and a skill set that other people do not. I have capacity to do things that people can't do, especially under emotionally stressful situations or emotional duress or something like that. That's part of what we're training to understand and to be able to do. So if you can start now thinking to not assume that other people know what you're talking about and to explain things, it's hard because you don't want to be patronizing to them and say like, well, I'm sure you don't understand trauma. And people are going to be like, yeah, well, everybody knows what trauma means, even if they don't. It's hard to find the balance of how you write about these things without being patronizing and without either over explaining or under explaining. And if you're a dude, you don't want to do any mansplaining because that's bad, I'm told. So, the other point to this is equal or greater training does not mean it is equal or greater. So if you have other people, attorneys, doctors, psychologists, whatever, who have more education, it doesn't invalidate or devalue your opinion. Sometimes you have to you have the opportunity to say, well, it's not the title that's carrying the validity of my opinion, it's the facts. And this is one of the responses that I would give a lot with attorneys when I have to work with them. Or I don't usually use that language with peers or like, you know, uh, other people. I don't get into arguments like this very often. But when I do, I say, I don't want you guys to take my word just because I'm professor, just because I have a PhD in this stuff. The education is there's a phrase, my degree is just a piece of paper, but the education shows in my behavior. Another way of saying that is that whether I'm right or wrong is determined by the facts of what I'm trying to say and the way I'm saying it, not just by who I am. You can't trust a person just because of who they are. It's because of the way they treat you and treat others and the things they say, how valuable and truthful they are. So, just because someone has more training than you doesn't necessarily make them right. So trust yourself, have confidence in yourself at whatever appropriate level you have. Don't be overconfident. Stay humble, but believe in yourself. If you believe in your I don't know, the truth of your assertions or something. I don't know, whatever. You guys get it. Um, think about whatever information other people need when you're communicating to other people, and what you can offer. I'm gonna move on from privileged communication. Maybe we'll explain this one in class. Maybe I'll talk about it for just a second. Privileged communication is a legal right that we have to maintain privacy, which it's kind of like when attorneys represent clients who are accused or allegedly have murdered somebody. They're not required to tell the courts that. It's the court's job to figure out if they've actually done it, you know? So they have complete and utter privilege in their communication, which means that they can say nothing. We also have legal protection to keep client information confidential with some caveats, and that's that informed consent stuff. Risk to self or others, risk to children or vulnerable adults, et cetera, et cetera. So it kind of goes to like be protective about what client information you're putting out there in the world. So I think that's enough I'll say about that. But actually, one other term. I heard a term, or one other thing to say. I heard a term recently that I thought was helpful. It was Brene Brown. I was reading her latest book, Atlas of the Heart, and she used the term story stewardship. I don't know if it was her term or someone else's, but when someone shares things about their life, they do that with the understanding that you'll keep that in confidence and that you'll protect it as if it was your story too. It's like if I had something like a fragile toy, it was my favorite toy, and I said, I'm going to let you have it, but I don't want you to break it. I want you to take care of it and treat it sensitively as if it was your own. I would want you to be a steward of that toy. It's the same thing with our stories. When clients come to us and they share these details with us about their pains, and they say, I trust you to not use this against me. That's what we're talking about here. So helpful term, I think. And then get releases of information. Yes, yes, yes. Can't say it capitally enough. And lastly, communicating with public. What I want to say about that, most of us are not going to be in situations where we have to communicate things with public, except maybe school counselors. If I were to guess, probably administrators are doing more of that, but how you share information with administrators is going to could be kind of important. But you should probably just ask your school counselors, supervisors, or whatever for more of that kind of information. But I just don't see a lot of us really communicating a lot of information with public. There has been a little talk about like people having social media profiles and communicating stuff on that, but also as much concern about should you even be communicating anything about client details publicly. It's one thing to say, here's an example, just very generically, without anything even close to identifiable. I've moved around enough in my career so I can talk a little bit, I think, about people that I once knew at a different place, but I still even try to be really careful about that. So anyway, I think that's it for this week. Hopefully next week I'll be back with a little, slightly less nasally voice because I always have a little bit of one. And maybe I'll do my hair next time and shave my face too. We'll see. We'll see. Maybe I'll grow it out just for a little springtime fun. I don't know. We'll see. Anyway, love you guys. See you later.